Thank you very much. We were interested what's happening with the proximal femur during growth in sports guys. And actually, looking back in the literature 50 years from now, Murray and Duncan, actually from England, have assumed that have done the first description of an association of sport and degenerative hip disease in 1971, and especially in young adolescent children. And they described a case, it was just an assumption, a bilateral tilt deformity in one subject, age 40 years. You see, this they called it tilt deformity at that time, with increasing pain over time. And they could follow this many groups of young athletes over some years and realized that there was increasing pain over time. And they just called or denominated 40% of so-called primary degenerative osteoarthritis of the hip appear to be a result, not of being idiopathic, but an abnormal joint mechanism, a minimal epiphysiolysis in adolescence. They thought this tilt deformity is a skiffy, a mild skiffy, and this tilt deformity is caused by chronic stress in children doing a lot of sports. So we were interested, can we, with modern techniques, can we really follow this assumption? But when we talk about chem-type deformity, as you have seen also in this paper, there's skiffy, there's tilt deformity, there's a lot of terms for not the same thing. Actually, if we talk about idiopathic chem deformity, it's an extension of the physis and the head towards the neck. You may also have a step off, like here, this may be called a slip-like or a mild unrecognized slip with this step here and this step inferior on the head-neck junction, and the clear post-slip deformity with a real measurable tilt of the head away from the neck. So when we talk about idiopathic or chem-type deformity developing during growth, we're talking about this type, and we have excluded skiffies or slips or other deformities. So we know that there's a significant higher prevalence of chem deformities in elite sports, in many sports, also soccer. We know also from different literatures they are rarely seen before the growth spurt. That means they're rarely seen or they have been described at the age of 30 years or younger. So we were interested when we start at the beginning of the growth spurt and follow these not patients, but sports kids over the years. What can we see in development of the physis and in terms of a chem deformity? We analyzed this before, during, and at the end of the growth spurt in ice hockey players here from Bern. 25 hips, 25 boys. So we had arbitrarily chosen one or the other hip in these cases, and this study was founded by the Swiss National Science Foundation over a period of 3 years. This was where we started. We started at about 12 years as a baseline before the growth spurt. 1.5 years we called them back, and we called them back with the middle of 15 years. You see there is a little bit a spread area because they were also sometimes in between 12 or 13 years. So these are just the mid values. We did our standard MRI, but not arthro. We would not have got the permission from the ethical committee, so there were non-arthro MRIs, because we just wanted to see the shape of the physis and the shape of the head, and this is sufficient without contrast. This is our statistics, and if you look at the epiphyseal angle as a first result, this is how far does the epiphysis extend from the middle portion of the head towards the neck as a baseline here. In terms of degrees, you see there was an increase of extension of this physis. It was not very impressive, but it was still significant at the 12, 1, and 2 o'clock position of the head-neck junction. And if you see this in the scheme, you see this is actually anterior superior, it's 12 o'clock, 2 o'clock is anterior superior. In that area, there was a significant increase or change of the epiphyseal extension over time. The other result was, what about the alpha angle? See, the alpha angle was around 45 degrees in all the locations with typical variations at the baseline. 1.5 years later, it increased, and it further increased at the mid-age of 15 years. And this again was significant now from 12 to a 3 o'clock position. It means in the anterior superior quadrant of the head-neck junction. Again, if you have this alpha angle, this was the first group baseline. There was no alpha angle higher than 60 degrees, so that was our cutoff. 1.5 years later, there were already some in this area, and at the end of the study, you see there was quite a significant amount of alpha angles higher than 60 degrees at the 2 o'clock position. Actually, 43% of this 15-year-old had an high or an abnormal high alpha angle. Again, if you overlay epiphyseal changes, alpha angles is somewhat the same area as has been described also already in an earlier study. There seems to be an association or correlation with these two effects. This also underlines that the alpha angle is a consequence of an abnormal growth, or seems to be a consequence. Growth plate status were all open at the beginning. Actually, 82% were closed at the time when we closed the study, so we still have some not completely closed phases. There might be even an increase of higher alpha angles over the time, and we probably intend to redo the study with 17 years in the same group. What about clinical data? As you can see in the initial, the range of flexion also significantly decreased over 3 years in the whole group. Also internal rotation decreased from average 43 to 23 over this time, and very important, 13% already had at the end a positive impingement test, and 19%, I would say, an abnormal internal rotation of 20 degrees or less. This is a model or a video where we summarize the growth over time in an MRI, and this is also probably my understanding how I think it develops. You see the more extended growth plate of the femoral head, and also this development of this abnormal shape and cam deformity at the anterior superior portion of the neck. One player, not patient, one player actually required surgery. He came in between at baseline. He had nobody had symptoms. He had no symptoms too. After this MRI, he was still going on to play, but then he developed pain, and he was operated actually on both sides with arthroscopy and resection of this cam deformity. So limitation, there is no longitudinal observation in a control group without high impact sports. We could not get it. We didn't get permission, or we did not get enough volunteers in schools. We were looking for that, but we could not make it, unfortunately. But these results go aligned with results described actually from Netherlands, where they did prospective X-ray studies on these young kids. I don't know how they can do it there. We would not get an allowance from the ethical committee to do X-rays. But after a minimum of 2 years in an age group 12 to 19 years, half of the normal hips showed a flattening or abnormality in their group, which is very congruent with our result. And they also saw in a longer follow-up of the same story after 5 years, the chem morphology resulted in an extended bowing of the growth plate and extra bone formation. This was a cross-sectional study, not longitudinal. We have done years back, and we found already this group, that in a sports group, there was a significant different shape of the growth plate and prevalence of an increased alpha angle. So in conclusion, before growth spurt, there is no evidence of abnormal shapes in the proximal femur. It seems very clear by this study that this really develops. It's a developmental problem during the growth spurt in the end, and it's a very high incidence I think 43% had a high alpha angle at at a 2 o'clock position at the age of 15 years. Thank you very much.